Hello, everyone. My name is Carlos Wambier. I'm an assistant professor of dermatology at Brown University, and I'm here today at the World Congress of Hair Research in beautiful Melbourne, Australia. I wish I was there, sorry, to talk about androgens and COVID-19. What's the current evidence? So it all started with the theory that maybe because DHT is involved in the pathogenesis of AGA and also in the pathogenesis of coronavirus, um, maybe they would be linked because DHT promotes a protein called TMPRSS2, which is a transmembrane protease that helps the virus to infect our cells. And based on that theory, the more androgen activity, the more vulnerable would be the patient because of increased viral load through cell infection. And while patients who have no androgen receptor, like androgen insensitivity syndrome, they would be completely immune to the virus. And well, I'll give you some data to support that theory that might be very interesting for everyone. On the largest population-wide study ever done for coronavirus, which is the Medicare data of 16 million patients, big data, we saw that the most important independent variables were age, followed by ethnicity, especially North American natives, followed by end-stage renal disease, and the sixth variable was being a man. So basically, men who are very old are very vulnerable, correct? Well, what is surprising is that there are some independent variables that actually protect from COVID. And one of them is prostate cancer, which happens in old men. Well, men, they only have one chance of having a protein, which is their androgen receptor, and they only have one chance of having one ACE2 protein because they only have one chromosome X. So if they have any variant of androgen receptor, a polymorphism that induces any vulnerability, they only have one X chromosome. And also, as I mentioned, the androgen receptor promotes a protein called TMPRSS2, which digests ACE2, which is the receptor for coronavirus, and it also primes the spikes of the virus. By modifying these two proteins, they have more affinity and the virus infects more the cells. And well, by looking at patients that were admitted in Spain, in Madrid, for coronavirus, our friends, researchers from Spain, detected that most of the patients were bald, and particularly men. 79% of men had some degree of AGA, while 42% of women. And we decided to call this the Gabriel sign because Dr. Gabriel was the first physician in the United States to die from COVID. So we thought maybe patients who are more bald, they have increased chances of having more lung damage by COVID. So let's look at outcomes. There's three studies that checked AGA and mortality. The first one was done in India, which they observed that those with the Gabriel sign died, while patients who didn't have a clinically significant AGA did not die in the hospital. And the more severe the AGA, more likely the patients were of dying. Another study from Peru observed the same thing. Patients with Hamilton-Norwood scale of more than 4 they had 22% of chances of dying versus the control, which only had 2. So it was 10 times the risk of death, which did not occur, for example, with age over 60 or below 60 at the cutoff. Another study from Pakistan with a larger population of 300 patients observed the same thing. The patients with the Gabriel sign, they died more, much more than the patients without the Gabriel sign. And also in women, there was also increased mortality in patients with higher degrees of AGA. So what about therapy to block DHT or androgens? Could that prevent deaths? Let's take a look. One observational study of patients who were being admitted and they were previously using anti-androgens. We detected that the patients that were using anti-androgens, they went less to the ICU, but there was a very small cohort of only 77 patients. There was also this observational study done in Brazil, where the patients were offered to take the usual care for all patients there, and among the usual care, they were also offered anti-androgens, and it was detected that the viral detection by PCR disappeared faster in those patients who were taking early anti-androgen therapy. And also the symptoms improved a little faster. Now, what if you started anti-androgens for patients who were hospitalized? There are 4 RCTs done, and here's the results. The first one ever published was this one from Iran, and they used finasteride 5 milligrams. They studied 80 patients. Half of them were randomized into finasteride. It was an open label study, and they detected that those patients were randomized for finasteride, they died less. They died at 2.5% died versus the patients who didn't use finasteride, 10% died of COVID. And their oxygen on day 5 was better if they were given finasteride. This is the largest study ever conducted with anti-androgen. It was done in Brazil. And one thing that we always have to keep in mind is that at baseline, their severity before enrolling the study predicts the outcomes. So in other words, patients who are not using oxygen and they're admitted to the hospital, they do much better than those patients who use a little bit of oxygen, and the patients who use high flow oxygen, they do worse, right? And if they are intubated, even worse. So we observed that the more the patient needed oxygen, the more the medication was useful to prevent mortality. While patients were not using oxygen, there was no statistical difference. And some cases had a very impressive improvement. This is a case of after 6 days. No one would expect a change on the CT scan after 6 days. There was another study done in Sweden that they did a lot of advertising saying that the study prostate cancer medicine, not a cure for COVID. It was a paid report by their university, and they're happy to show that their study didn't work, even though their study was very small, only with 45 patients, and it was open label. They said it was randomized, but somehow the arm that was randomized to enzalutamide had many more patients that were severe at high flow oxygen. But despite that, none of them died, while on usual care, that they only had 1 patient on high flow oxygen, that patient died. And they couldn't even see that in their own data set, so we had to write a letter to warn them. And we also noticed that their own data was showing that the viral load on the control arm increased in 4 days and then went back to baseline after 6 days, while their enzalutamide arm, the viral load decreased at 4 days with statistical significance and then continued to decrease on 6 days. And even by pointing that, the author said that still they didn't see any benefit. And another study conducted here in the United States by the VA and the UCLA, they tested this medication called the Gerlix, and they also didn't see any result. They terminated the study early, and just by requesting their data, they told us that patients who were needing oxygen at high flow that received placebo, they were blinded, randomized, 50% of the patients died, versus those who received the Gerlix, 33% died. And they terminated the study early. Maybe if they recruited 10 times more patients, it would be statistically significant. There's another medication called sabizabulin, who's a blocker of the androgen receptor by not allowing the androgen receptor to enter the nucleus. It was given for up to 21 days in patients who were very severe, and they detected that there was 55% reduction in mortality with this anti-androgen. The placebo group, about 45% died, while sabizabulin, only 20% of patients died. And this medication, somehow, it was not given emergency use authorization in the United States, while other medications such as remdesivir, monoclonal antibodies, they were given emergency use authorization, despite never really changing mortality rates. And what about these external androgens? Could that change the outcomes? Could they do better or do worse? Well, we have some evidence. There's the study from Saudi Arabia who showed that on their retrospective data, the patients who were using anabolic steroids, they had more severe COVID. And there was a case report of a single patient who was very young, 28 years old, and he was using oxandrolone, which is a DHT analog, and he had very severe symptoms. And after receiving an anti-androgen, on the next day, he was feeling much better. His oxygen levels are better. His inflammation was better. And there are many cases on the internet of very young, healthy men who are using anabolic androgens who did really bad with COVID, receiving CMO or dying. And there's this report of a 34-year healthy man who was using steroids, anabolic steroids, and he had a very severe COVID with endothelial damage, and his heart, he had this myocarditis with extreme endothelial damage. Well, another thing that is interesting to observe is that usually myocarditis happens more in women. Viral myocarditis usually in women, but somehow COVID myocarditis happens more in men, especially younger men. And well, the same thing also happens with the vaccination. Basically, this was the first large series of myocarditis reported, with one fatal myocarditis in a young man. And they noticed that 94% of myocarditis by the mRNA vaccine from Pfizer happened in men. And the incidence of myocarditis actually increased right after the second dose of the vaccine. And it is estimated that 1 in every 50,000 people who receive the vaccine develop myocarditis by the study, or younger men below 30, about 1 in every 10,000 young men. There's this other study recently published now in November that they showed that the Moderna vaccine had 5 times the risk of myocarditis in these very young patients below 30. So it's about 1 case in every 4,000 young men. So in conclusion, men are more vulnerable to COVID. Among men, AGA predicts outcomes. Young men have more risk of myocarditis from mRNA spike protein vaccines. And just to remember, the tennis player that was not allowed to enter Australia, even though he had COVID before and he was naturally immunized. It is important to respect the individual decision and always respect the procedure of having an informed consent form, a free and informed consent for any medical procedures. Thank you very much. Here's my contact if you want to share your opinion or your experience. Wambier MD on Instagram or Twitter. Thank you very much.